There you are. Gotcha, Femi. Got you, Femi.
Have you got him?
Yeah, gotcha.
I can't see you though.
No, I can see you.
Yeah, okay, all right. I suppose that's all that matters.
Femi,
Yes, sir.
what shall I say? How would you like to be introduced?
Not much. I work at Heart Fertility Clinic as a specialist, and I'm still part-time at Critics Care.
Okay.
And that's pretty much it, yeah.
Okay, I'll do that. And
Okay.
And Steve's also joining us, but I don't see him. Is he coming?
Yeah, he'll be here soon. I'm going to start the intro video in a minute, and then so he'll probably join us in the next 5 minutes or so.
Okay. Wendy, do we have a sponsor?
No, we do not have a sponsor tonight, Doctor.
All right. Okay, thank you, Wendy. Wendy, is Karain now on maternity leave?
Yes, she is. She is
good.
ready to get that baby.
Even I know that.
I won't ask why, Femi. I won't ask why. Okay. Now, Femi,
yes.
Would you mind? We've got a lot of interest over here, and usually what happens is that people ask questions. Can we interrupt you as the time as you speak, just to have that sort of time, sort of one-on-one interaction that people would have in a talk, as it were?
Sure, I'm happy to do that. Also, the talk is not an hour long. There should be time at the end. I think the relatively short talk, actually. So there should be time at the end for discussions if people want to put their thoughts together. But we can do it as I go along. You just tell me you have a talk, we want to talk about something, and we'll talk about it.
Okay. Let's see here.
I'm going to start the video now, the intro video, and then the people will start joining. Is that fine?
Okay.
Are we okay with that?
Thanks so much then, Wendy.
Thank you, Doctor.
Well, good afternoon, ladies and gentlemen, and a warm welcome to everybody from the Pelvic Floor Foundation in South Africa, from Cape Town. It's a great honor we have this afternoon to have Dr. Femi Laragon. He is, as you know, head of the Heart, that's the fertility clinic here in Cape Town, and a part-time consultant at the University of Cape Town and Groote Schuur Hospital. With me this afternoon on the webinar is Professor Steve Jeffrey, as you can see over there on the right-hand side. He's smiling now. And we look forward greatly to having you, Femi, present on the subject of embolization of uterine arteries at the time of fertility and the consequences thereof. The afternoon is sponsored by the Pelvic Floor Foundation of South Africa, and a great big thank you then to the Directorate of the Pelvic Floor Foundation. I'm going to ask Steve, would you introduce and say a few words about Femi Laragon?
Absolutely, yeah, no, it's wonderful to have Femi. He's a very good friend of mine. I mean, Femi and I were registrars together, and we've been going through our careers together. It's wonderful to work in the same hospital as Femi, but Femi really has taken up UFE, and really, without a doubt, one of the first adopters of the technique, and also really a huge experience. So I don't think we can have a better person yet to talk about this very important subject. And I think it's maybe something that we don't think enough of, Pete. And for the right indications, it's a wonderful option. So I'm really looking forward to hearing about a very important part about fertility, which is probably one of the most important aspects of this treatment, and really trying to understand it. So Femi, we're very happy to have you, and I think you've moved office as well recently, haven't you? But still part of the Heart.
Yeah, so Heart. Sorry, am I muted, or can you hear me?
We can hear you.
Yeah, we can hear you very well, Femi.
Great. So we have moved to the new Cure Clinic, just across the road from Christian Barnard. So, but Heart Fertility stays the same brand. It's just a different geographical location, if you like.
Well, it's great to have you over here, Femi. Just to remind you that next week we have Dr. Judy Klucher, and she's speaking about urological conditions during pregnancy. So that's another very, very important topic we're going to be addressing. Now, without further delay, I'd love to have Femi's take on uterine. Can you just give us your first slide, please, Femi? Are you able to share it with us?
Yep, it's coming up in 2 seconds.
Sorry, Pete, just from my side, while Femi's getting his slides on, Gary Soetvaart, who's also, he's a radiologist, and I think you've worked together with Gary for a long time, Femi. He is actually with us tonight as well. So, he'd be able to give some input if there's anything from a more technical radiology point of view.
That's right.
Thank you very much indeed. Okay, Femi, pregnancy and fertility following uterine fibroid embolization. What do we know and what don't we know? Femi has very graciously allowed us to have timeous on the hoof questions. So if anybody over here wishes to ask questions as they occur, it'd be wonderful just to put them up and we can address them to Femi. Thank you very much indeed. Femi Laragon.
Thank you so much. Very generous introduction. I appreciate it. I also think that picture that was showed earlier is about 15 years old. I've gotten a lot older since, and I think we need to change that. So I'm going to just go through the scale of the problem that we all deal with every day. I think every gynecologist deals with fibroids every single time. Probably every single day of our practices, we'll probably have a patient coming in with some kind of fibroid problem or the other. So they affect about 50 to 60% of all women. As we know, they're benign smooth muscle tumors of the uterus, the most common tumor found in the female reproductive system, present in up to 40% of women menstruating over the age of 50 years. And of importance is because we practice in Africa, we see a lot of dark-skinned people. And I think it's a different kind of fibroid that we see, and we'll talk a bit more about that. But it occurs twice as frequently in Black women compared to their Asian and white counterparts. So you want to say something, Pete?
Sorry, no, that's sorry, Femi.
All right. So just a bit of historical perspective to uterine embolization. Embolotherapy itself has been used for years, in treating target organs like lesions in the liver, perhaps in the kidney and stuff like that. But not until 1995 was the target organ actually was fibroids in the uterus. And this came about with Ravina et al., who practices from France. And he had a group of patients who were on a waiting list, to have a hysterectomy done for fibroids and bleeding. And while they were waiting for this, he decided, let's embolize the fibroids and see what happens. And the consequence of that is that there were about 16 patients on that list. 11 of them had complete resolution of symptoms. 3 had partial resolution. 2 went on to have further surgery. All of those patients successfully completed, the process of having UFE done. So it was easy to do relatively. And at 20-month follow-up, uterine volumes had reduced by about 20 to 60%. This was published in the Lancet in 1995. So that was our first introduction into UFE. But since then, it's now become such an integral part of what we do. And I spoke about UFE about 2 years ago on this forum, and it's going to be a different slant, this time around. But up to about 2022, the number of fibroids being embolized around the world is about 13 to 14,000 procedures in the US alone. And just to have a bit of a South African perspective, there are 2 major clinics that we work with, or 2 major practitioners that do fibroids that we refer to and that we work together with. The one is with Gary Microsurgery South Africa, and as of March 2022, between July and March, he'd done about 2,000 cases, and I had a chat to him briefly a couple of days ago. And he does in his clinic about 350 cases, a year roughly. So quite a busy one. And then the other one is Fibroid Care with Dr. Lawson. And up to about 2022, when I had this slide made, he had done about 1,500 cases. We would look at what more of the regular figures are now. So the slant we have on this topic today is, how does it affect fertility? Does it work? I think we know that. We'll try and answer that question. But where do you put it as far as when we're trying to conceive is? Just to give you an idea, this is a recent study published April 2023, Journal of Vascular Interventional Radiography. And what they did was take a survey of 112 gynaes, or we sent out a questionnaire, trying to get a feel for when they will prescribe UFE for patients presented to them with symptomatic uterine fibroids. And they got a response back from about 112 gynaes in the States. And then the striking thing is that overall, UFE was only offered as a first option to treat fibroids in less than 2% of cases that came to these practitioners. And in fact, if you are seeking fertility or seeking to maintain your fertility, and you have fibroids that are symptomatic, UFE was prescribed in less than 1% of cases. Myomectomy was offered in 42% and medical therapy in about 54% of cases. So it just gives you an idea where people's minds are at. I venture to say that perhaps in South Africa, we're not that much different. There are a few practitioners that do, probably use a lot more uterine fibroid embolization for this indication, but I think by and large, most gynecologists probably still go to traditional ways of dealing with the problem. So what I'm going to try and do is just answer a few questions. These are the questions that kind of, come to mind when we're thinking about uterine embolization and fibroids. First one, is it effective in treating fibroid symptoms? Can patients have successful pregnancies following UFE for fibroids? Should we be offering UFE to women who are trying to conceive? Should UFE be offered to women when pregnancy may be in the future? So patients who are not trying to conceive at that particular point in time, but may want to conceive later. Is ovarian reserve affected adversely in women after UFE? Is pregnancy outcomes worse in women after UFE compared to myomectomy? These are sort of things that one needs to think about. And do we have any local data? So is UFE effective? I think that's pretty straightforward. No matter what literature you're looking at or where you're doing your search or whatever you're looking for, there's absolutely no doubt that if you got fibroid-related symptoms, namely heavy periods and painful periods, you're going to have resolution of symptoms in about 71 to 92% of cases after UFE. And this cuts across, it works if it's done properly. Patients do well. And they like the fact that it's minimally invasive as well. Fibroid sizes, if you're talking about volume, so pressure on the bladder, pressure on the rectum, and just, big fibroids that cause pressure issues, the volume is reduced by about 42 to 83%, following UFE. Patient satisfaction is high, so over 90% of patients will tell you that they are satisfied with the procedure. And the complication rates are low. It's a safe procedure, so compared to the other alternatives, other surgical alternatives, the complication rates are quite low, about 1.25%. And if you're looking at major complications, that's probably in the region of, much less than 1%, probably 0.5%. This compares favorably with the other, methods of treating fibroids that we have. So to answer that question, it's a resounding yes. UFE is effective, it's safe, and it's something that we should be offering. So do we have successful pregnancies after UFE? We're going to do a bit of sort of diving around here as far as literature is concerned. The first one is looking at Parker et al. This was published in Radiology, in the Radiology Journal in January 2020. And what came out of that paper and what we all articulated quite well is the fact that the concerns post-UFE, as far as fertility are concerned, include conception. So does it affect conception? If you've had UFE, is maintaining a pregnancy a problem? Does it predispose you to premature menopause? If you've had UFE, is the radiation exposure for that space of time a problem? Are your risks of preterm delivery, postpartum hemorrhage, and spontaneous abortion increased? There's absolutely no doubt that, and we all know that uneventful full-term pregnancies, healthy pregnancies, are reported following UFE. In fact, most pregnancies following UFE are uneventful. I think we need to remember that. The complications are there following UFE, which we'll talk about now, but most pregnancies following UFE are actually normal pregnancies with normal outcomes. Confounding variables exist as far as all these studies are concerned, and this will include the fact that a lot of patients that have fibroids have advanced maternal age. There's uterine wall compromise either because of the fact that they do have fibroids, which compromise uterine wall, or they've had prior uterine surgeries, including previous myomectomies before and previous instrumentation for one reason or the other of the uterus. And there are varying levels of skills as far as interventional radiology is concerned that might affect the level at which the response you get, from the symptoms and how the patient does subsequently. And importantly, the other unknown causes of infertility. So a lot of these patients, if they don't come through a fertility unit, perhaps have not been investigated for other causes of infertility, and fibroids have been concentrated on, and that's what's been treated. And that would affect and skew your what you find as far as pregnancy is concerned, after UFE. What are the actual pregnancy rates following uterine fibroid embolization? It's pretty uncertain because it varies significantly depending on the literature that you're looking at, but it's been estimated that approximately about 38.3% as far as Parker et al. Is concerned in patients under the age of 45. And this came from this group of studies that was looked at that particular point in time. The studies that you can see are on top there. So Pawan et al., Mara et al., Kim and McLucas, in years ranging from 2001 to 2008. The bottom line there is the total number of subjects, usually under the age of 45, some of them under the age of 40, who indicated that they had a desire to maintain fertility or become pregnant at the time of UFE. And at that particular point in time, when they were offered UFE, they were hoping to get pregnant or trying to get pregnant or hoping to get pregnant in the future. And you could see the percentage pregnancies there. So on top there. And if you put that all together, it comes out to about 38.3%. So that's probably what we're looking at as far as pregnancies following UFEs are concerned. So I'm going to toggle a bit between this slide and the next one. It's a busy couple of slides, so just bear with me. On what basically it's just looking at the different trials that have been done. They're often quite small trials. And then it's looking at the level of conception following the trials, the patients who've had UFE done. and then what the complications have been, in those pregnancies. So namely, I'm going to move Peter away from there, namely spontaneous abortion, preterm delivery, and cesarean deliveries as the main things that were being looked at. If you look at this is a continuation of that, so bearing in mind what I said there, spontaneous abortion, preterm delivery, and cesarean delivery. If you look at the bottom line here, that's comparing it to the general population. So conception, 75 to 95%, cesarean section rate, 31%, preterm delivery rate, 12.6%, and then the rate of miscarriage is 15 to 25%, the general population. And if you just follow it up there, and that's just what I wanted to bring out. If you look, I don't know if this shows, there we go. So up as far as abortions are concerned or miscarriages, those figures are significantly different. So 50.6%, 29.4%, 44%. And if you look at cesarean section rate, also significantly higher than what you expect in the general population. Having said that, you and I know that most patients that have myomectomies, which is your other alternative if you're comparing sort of apples with apples, as far as trying to conserve fertility is concerned, would have a cesarean section delivery. I venture to say that the cesarean section rates in patients with myomectomy will probably be north of about 80%, across board, especially the intramural fibroids. So that will bring that down. Then the rates of things like preterm delivery and miscarriages are probably higher as well in patients who've had sort of myomectomy. So, it's higher than the general population, okay, but the patient that we're talking about here, they had fibroids to start with, and now they've had an intervention for the fibroid, and then you're looking at then what happened as far as their pregnancies are concerned. So just to put that into perspective.
Amy, there's a question here from Willem Combrink about any studies that have been done that compares. He says AMB, but maybe it's AMH pre and post UFE. I don't know what AMH. Yeah,
AMH, I think it's probably talking about AMH, and I'm sure you can correct us. Yeah. There's been a few, and I will allude to one or two as towards the end. And I'll talk about AMH as far as UFE is concerned a bit just towards the end of the presentation.
Okay.
Yeah. Right. So this is now looking a bit more into detail of some of those trials that I've mentioned earlier. Walker and McDowell, this is probably one of the bigger sort of series that we've had. And they've reported a series of about 200 pregnancies over a 9-year period of UFE for fibroids. Of those 56 pregnancies, were in 108 women trying to conceive. And of those 56 pregnancies, 59% of them had term deliveries, 6 preterm, 17 spontaneous abortions, 2 stillbirths, 1 ectopic, and 1 elective termination. And about 2/3 of those patients were delivered by cesarean section. When looking a bit into more detail about that particular trial, they looked at 57 patients desiring to maintain fertility in their cohort of 100 UFE cases. 11 pregnancies were reported in 10 women, so 1 woman conceived twice. And in that cohort, they had 8 live births, 4 vaginal deliveries, 4 cesarean sections, normal birth weights and placental morphology. For all the babies that were born, there were 3 spontaneous miscarriages. Average follow-up was about 2 years in this study. These are obviously quite small studies and small numbers, and that's what you often find when you're looking at literature for this particular thing. The Maya trial is probably the one that does compare apples with apples in terms of trying to maintain, sort of keep fertility going. And that was a randomized prospective trial comparing UFE and myomectomy. Probably the downside of that trial was the fact that there were unequal numbers in each group trying to conceive. So in the myomectomy group, there were 40 patients, and the UFE group, there was 26 patients. Importantly, the perinatal outcome, including the birth weight, preterm delivery, cesarean section rates, and postpartum hemorrhage rates were similar in both groups. Spontaneous abortion rates were, however, higher in the UFE group, 64 significantly higher, 64% versus 23% in the myomectomy group. Pregnancy rates, 50% versus 78% in the myomectomy group. So as far as this trial was concerned, the women were more likely to get pregnant if they had myomectomies and less likely to have a miscarriage. But what I think is also important is the mean age of this trial participants. The young patients. These are patients who still have the ability to conceive. At least this group that was looked at, and that's why those figures are what they are. Pretty good figures. But because these patients are young, what I'm trying to say there is that piggyback onto the back of the AMH and ovarian reserve. When you have ovarian reserve, when you're younger, that is pretty good. You're more likely to sustain that whatever you do compared to patients who are closer to 40, for instance. But we'll talk a little bit more about that in a second. So what about the South African experience, fibroid care, is Dr. Lawson, and he basically gave me data for 2020 to 2024. It's important to mention that he doesn't offer UFE to patients. I think probably most of the patients that we work with, or the doctors that we work with that do UFE, don't offer UFE to patients that are trying to conceive. So if you're trying to conceive, we'll probably send you down to a fertility specialist wherever you are. And so these are not patients who are actually trying to conceive. These are patients who came to see him because they have symptoms of fibroids. And if fertility was an issue, we'll probably then send them across for an assessment. So there were about 940 patients in that group of time that we looked at. Patients less than 40 years. In that group of patients, you had about 15 pregnancies, and this is out of about 310 cases below the age of 40. Patients over 40 years, they have about 630 cases, and you can see only 2 pregnancies in that group. But it's important again to mention that in the group less than 40, 32% of these patients, so 1 in 3 of this group, had a previous myomectomy, have blocked tubes, morbid obesity or comorbidity that made surgery undesirable for the gynecologists that were involved. So if you exclude that, saying that those are things that would prevent the patients from getting pregnant anyway, it's a very general exclusion, then you could probably bring that number right down to just over 200 with 15 pregnancies. Also importantly, talking about AMH and ovarian reserve and the incidence of premature menopause, in that whole cohort of 940 patients, he had 1 patient that had premature menopause following, during that follow-up period that he had. And this is looking at microsurgery clinic with Gary. And like I mentioned earlier, an average of about 350 cases per year. And this was data collected from between 2016 to 2022. And in that data, we have patients, we have 34 pregnancies from 33 women, again, 1 woman there conceived twice. In the patients under the age of 40, there were 31 pregnancies, and over the age of 40, there were 2 pregnancies. The causes of the pregnancy, how the pregnancies went, as far as South Africa data is concerned, we don't have yet. It's something that we could probably, and we're talking about trying to get that. So what's the incidence of abruption placentae, placenta previa, preterm deliveries, postpartum hemorrhage, in those group of patients? The numbers that we could potentially get, it just takes a bit more work. But, going forward, it's probably something that we need to look at and try and obtain. So I just thought, we'll talk about UFE and looking at patients who actually have fibroids in place. So, we all deal with patients who've got fibroids. If you're still doing, if you're doing obstetrics, more often than not, you will have, patients who, you're taking care of that have fibroids. If we compare that group of patients to patients who've done embolization, who've got fibroids and had treatment for the fibroids, are there similarities? Are there sort of differences? And there was a systematic review by Omar Saridogan published in Fertility Sterility 2010, and they found there were similar rates of preterm delivery, IUGR, and malpresentation in both groups. So a group would have UFE and a group would have fibroids in pregnancy. Post-UFE pregnancies had increased risk, however, of miscarriage, cesarean delivery, and postpartum hemorrhage. So these are patients who have not had intervention compared to patients who've had some intervention. The odds ratio for those factors were 2.8, 2.1, and 6.4 respectively, with confidence intervals, as you can see, not crossing 1. And, so it's significant, when you look at it from that particular study. There was another one which basically randomized patients into doing UFE and doing nothing as far as their fibroids are concerned. And they looked at a number of patients. This was published in 2010 as well, fertility sterility. They found fertility and miscarriage rates were similar between age-matched females who had undergone UFE and those who elected to receive no treatment. So again, what I'm trying to bring out here is that there will be the fact that you've got fibroids already puts you at kind of a high risk category as far as your pregnancy is concerned. Whatever you do subsequently on top of that obviously makes it sort of, perhaps a bit more difficult. All right, should we be offering UFE to? Yeah. No problem.
Willem Combrink is just asking one other question, and is whether referring to spontaneous or ART pregnancies in these, or is it a mixture?
This is a mixture. These are patients. You mean, is he talking about in patients, the UFE versus?
The UFE patients.
Okay, so the pregnancy rate, the 38% pregnancy rates in UFE patients are patients who conceive spontaneously.
Okay.
Yeah, the studies that I mentioned earlier, spontaneously conceived patients. Yeah. All right, so should we be offering UFE to patients who are trying to conceive? So a patient comes to you, a couple comes to you, they are trying to conceive and you found that they've got fibroids. Is UFE an option? Now, it's important to realize that when you're trying to conceive, there are a lot of other factors. So we tend to see patients who've had myomectomies done. As the patient walks in, there's no semen analysis. There's no indication to check whether the tubes are open or not. There's no indication whether this patient has had endometriosis excluded or other causes of infertility. So what I'm trying to say is that before you put infertility down to fibroids alone, investigations for other forms of infertility, other causes of infertility must be done. Otherwise, fibroids doesn't always cause infertility, and you might be tackling or even making the problem worse. So in women who are trying to conceive, full investigation is necessary to make sure there are no other causes of infertility, so that if you're then offering them a form of treatment, it's a form of treatment that is what will solve the problem, having taken care of everything else. Oftentimes, time is a factor as far as patients trying to conceive are. So they are perhaps in their late 30s because they've tried to do other things before they try and conceive, and they're trying to conceive. And that group of patients, you probably would not be offering them UFE, because those group of patients, you need to get an answer quickly, and you need to perhaps move them to IVF pretty quickly. So you start thinking about ART in the older woman rather easier than you would in a younger patient. So you don't have that much time to actually offer uterine fibroid embolization in those group of patients. You probably just want to go straight into a myomectomy. At the same time, if you're doing a laparoscopic myomectomy, for instance, you can then assess the tubes, which then gives you a fuller picture. You can assess what's going on in the pelvis, which tells you if it's got endometriosis or not, and deal with those problems at the same time. So it's a more complete way of dealing with the patient if you're offering them laparoscopic myomectomy or myomectomy compared to UFE, patients who are trying to conceive. I've just mentioned that not all fibroids need to be removed, so we need to think about that. And obviously, the concerns about ovarian reserve and pregnancy outcome, like we've discussed, it needs to be brought into the equation as well. Now,
so Femi, sorry, just another question here.
Yeah.
So it's again from an anonymous attendee, and just really, obviously there are different sizes of fibroids. So the question is, did any of these studies look at the size of the fibroid and the locations, and did this have effect on the outcomes?
No. So
just there.
There's small studies. As you can see, the numbers are not not huge.
Absolutely.
So it's difficult to separate all those things. So generally speaking, there are large fibers. Most of them will be fibers that are at least more than 4 centimeters. And I think the point is valid, because fibroids, but they're not necessarily the same across the world. So the kind of fibroids we see might be different from fibroids that are seen in Sweden, for instance, in terms of how they present the sizes and the numbers and all that. And I'll allude to that in a couple of seconds. But those trials that we have from the big trials that we have, big trials in quotes that we have from Europe and America, are trials that just looked at fibroids. So not necessarily distinguishing between the size of the fibroid. But it's important to also mention that the size of the fibroids does not does not affect whether or not you offer them UFE or not. There's no size cutoff as far as UFE is concerned. You can do UFE for very big fibroids as well.
Femi, you've got a lot of experience with this. Just a question from my side. I mean, what sort of reduction in size do you actually get? Let's say you get a huge 30-week fibroid uterus. I mean, what do you actually see? Does it go down 50%, 20%? What are you looking at?
So the figure, and it will come up in the figure you're looking at is about, you quote between 40 to 60% on average over like a 9 to 12 month period. So that's the fibroid volume shrink. If you have concomitant adenomyosis, for instance, then you don't have the same level clinically that you will get if it was just predominantly fibroids. And it also depends on how well the UFE was done. But the general figure you have is probably about 50% in about a 9 to 12 month period. That's kind of a kind of place you can actually pitch as far as the patients are concerned. Right. So this group of patients are different from the ones I've mentioned. I've spoken about patients who've come to you who are trying to conceive. And those group of patients, I think it's clear that you need to offer them a myomectomy if you think it's indicated. So in other words, you've done everything else, the fibroid is a problem, they have a myomectomy. Now, what about if fertility is in the future? So you've got a woman who's 25, 24, and we see fibroids, big fibroids in this group of patients as well. Already with symptomatic fibroids, 22-week size fibroids, 20-week size fibroids, severe dysmenorrhea and bleeding. What do you do with this group of patients? In other words, do you offer them UFE or should we offer them myomectomy? I can tell you that most patients that I've seen later on have been given myomectomies, based on this, sort of scenario that I've presented. But is that the right thing to do? The RCOG guideline suggests that the evidence for fertility and pregnancy outcomes after UAE and after myomectomy is poor. I think we just said that small numbers, not big circles, not randomized, so there's a lot of, sort of people grappling around trying to find what the truth is. Similarly, there's no robust evidence comparing UAE or myomectomy for these outcomes. Currently, it is impossible to make an evidence-based recommendation about treatment, UAE or myomectomy for women with fibroids who wish to maintain their fertility. So treatments for fibroids in women of childbearing age who wish or might wish to become pregnant in the future should be offered only after fully informed discussion. So they basically sit on the fence here. They're not saying this over the other, myomectomy over UAE. They're saying both of them are available, do the pros and the cons, have a discussion with the patient and see how it goes. There was a Cochrane review by Gupta and colleagues published in 2014. And on the basis of some of the other trials that had been done, suggesting that myomectomy was better in terms of pregnancy outcome and fertility outcome, they were suggesting that there's insufficient evidence that myomectomy improves fertility compared to UAE, whether by laparoscopic or open approach. So again, a school of thought there, it's not clear-cut evidence that if you offer them UFE, you're doing a better job compared to if you offer them myomectomy or vice versa. But having said all that, despite the conclusion by Gupta, the guidelines by the gynecological societies in France and the US still recommend myomectomy over UAE for symptomatic intramural and subserosal fibroids in women who wish to have a subsequent pregnancy. So the Americans and the French on one side pretty much saying this is what you should be doing, recommend myomectomy over UAE, Royal College guidelines as I've discussed. And the Cochrane review is what I've mentioned as well. Let's just introduce very quickly what this time factor thing is. The recommendation when you do a myomectomy, especially if it cuts into the uterus, intramural fibroids, is that the patient waits about 3 months for kind of recovery of the uterus and full healing, and then perhaps has a window of about 6 to 12 months to conceive before the risk of recurrence becomes a factor. Now, the risk of recurrence for fibroids is quoted anything from between 7 to 8% to up to 51%, depending on the group you're dealing with. So the risk of fibroid recurrence is quite high. And that's also there because some of the smaller fibroids are not always removed when you're doing a myomectomy. And I've seen a lot of patients who had previous myomectomies and they've come to you, within a short space of time for IVF, for further treatment, and you still find a fibroid in the cavity. And I'm sure everybody that practices in this field will tell you the same. If you do it laparoscopically, there's no tactile feel. If you have an MRI beforehand, you should know where the fibroids are and go after them, but that's not always the case. If you're doing an open myomectomy, sometimes you don't actually feel the small ones that are quite there. You might actually miss them. And those ones are the ones that tend to regrow. So say you do it properly, you have a short space window of time, and then you start worrying about recurrence. So in that group of patients, it's important to notice that there is a time factor that one needs to think about. So in a patient trial, I've mentioned that before, patients trying to conceive, you have to think about that. But in patients who are much younger, perhaps it's a different story. So what about ovarian reserve? That's this question I was asked earlier. So the ovarian reserve story is got to do with when you embolize in fibroids, you're in the pelvis, embolize in vessels in the pelvis, there is a chance that you inadvertently embolize other vessels that supply the ovary, and in that way take away some of the ovarian supply or ovarian reserve that the patient might have. And in that way affect their fertility or maybe push them into premature menopause. Now, there was a Cochrane systemic review of 15 prospective cohort studies and RCTs, and they found that loss of ovarian function after UAE occurred primarily in women older than 45 years of age. So what it is if you're older than 45 years of age, and you have a higher chance of that happening than if you had better ovarian reserve when you're younger. Harkin et al. In another recently published trial, I think this was in 2022, they actually found that UFE did not significantly affect AMH levels at 3 months post-embolization. So having looked at the literature, what I found is that AMH may or may not decrease depending on what you do as far as UFE is concerned. What I mean by that is that if you're doing AMH at 3 months or you're doing it at 12 months, you might find that it actually decreases at 12 months and then recovers at decreases at 3 months and then recovers at 12 months, especially in the younger patients. So it's not entirely clear that if you do UFE, you are knocking off ovarian reserve. I think you probably are knocking off ovarian reserve, but in the younger patients, they have enough reserve that it's not so much of a factor. And in patients who are, closer to 40, perhaps, for instance, or closer to 45. I guess by 45, it doesn't really matter as far as fertility is concerned, but closer to 40, we would worry about it. And, so there is evidence that the younger women are less affected when you're, talking about loss of ovarian reserve following that. Right, so let's try and make some sense out of that whole thing that I've been talking about. There's still a lack of clear evidence that myomectomy is superior to UFE in the treatment of symptomatic fibroids. I think that's clear. I've tried to, try and bring out different studies that want, pro and against, but the fact is that there's no clear evidence that one is over the other better as far as the literature is concerned. There are likely poorer pregnancy outcomes. I think that's probably a fair comment following UFE compared to myomectomy. We do not have the big trials to back it up, but from what we have, things like miscarriages and postpartum hemorrhage rates are probably higher. The other parameters that you saw in some of the other trials, it really remain the same in both groups. In women trying to conceive at that particular point in time, myomectomy is still probably the best option. In women where fertility is in the future, strong consideration should be given to UFE, as ovarian reserve is less affected and smaller fibroids are taken care of. So we tend to see more aggressive fibroids in young African women. They start earlier, you take them away, they come back, and they come back with a vengeance. So within a couple of, within less than 2 years, you might have recurrence and a lot of fibroids. And perhaps it's time to start thinking we should try and avoid that first cut, because we know it's usually the deepest, right? So the idea is maybe in those women, we should be thinking of offering them. They have good ovarian reserve, take care of their fibroids in a less aggressive way, and see, and then watch how it goes. By the time they're 33, 34, perhaps you've done them a huge favor. And if they still need to have a myomectomy, it's something you can get back on. What we tend to see is patients who have myomectomies at 25, maybe even earlier, and then they have a repeat myomectomy at 32. They're trying to conceive, they're now in their late 30s. They've had 2 previous myomectomies. There's Asherman syndrome, there's adhesions and the uterus doesn't actually function as well as it should be. So that's the kind of scenario that we should try and avoid, and maybe UFE offers us, you know, an option there. Thank you very much for listening. I appreciate it.
Well, Femi, thank you so much. It's been wonderful hearing you. We've got a whole lot of questions over here. If I can start, Steve, if you don't mind. We've got an anonymous here. Anonymous, that sounds like Habib M. Habib again from Nairobi. He calls himself anonymous, but we recognize him from his email address. He says, number one, what are the complications, or one might reasonably expect post-uterine fibroid embolization? The surgical complications.
Okay. Sorry, this talk was about fertility. The other one, you know, I obviously try to leave some of those things. The complications are not a lot. The one that I suppose we see often is if you have a submucosal fibroid and you've embolized it, you basically kill that fibroid and the fibroid needs to be expelled. So the patients often have like a discharge going forward, a foul swelling discharge because of that dead submucosal tissue in there. And what is that, you know, to try and avoid that, what we say is you should have a plan beforehand, either to go and remove that, to go and do a hysteroscopic resection prior to the UFE or shortly afterwards to try to prevent that from happening. So that's one of the things that can happen. Most patients, by and large, do well. They have a lot of pain in the first 48 hours. There's something called post-embolization syndrome, which they probably all get to an extent, but it's not an infection. So that is treated aggressively with antiemetics and painkillers and all that. But a small percentage can get infected, and I'm talking about less than 1%. And in those group of patients, you need to make a difference between PES and infection, because the infection group will need a hysterectomy as well. So the chance of doing a hysterectomy for infection is quite slim, but it's one of the complications that are recognized. And I suppose the other one is embolization of non-target organs. So in other words, especially in the early days of UFE, there was embolization of the bladder dome, embolization of parts of the other parts of the pelvis that you did not want to embolize, and those complications. But that's a lot less now. And I'm sure Gary would mention it if we ask him to talk, because the guys are a lot more skilled at what they do, and the catheters are a lot better, so the chances of that happening is also quite slim. So those are the main things. Generally speaking, it's well tolerated.
Just to finish another one of his comments, the cost of uterine fibroid embolization versus myomectomy. Do you have any data, Femi?
The data I have is totally my data. In other words, when a patient comes to me and she needs to, you know, she has options in terms of the two, what does it cost them? And I can tell you that uterine fibroid embolization in a cash paying patient will probably cost in the region of between 70 to maybe 100 grand, depending on what you're offering them and where it's being done. And Gary can chip in. And if you're offering them a laparoscopic myomectomy, you're probably not going to get away with less than that. That's where you know, so it's probably about the same, to be honest. With the laparoscopic myomectomy, obviously they stay in hospital for a couple of days. Same with the UFE. So that all comes into the equation. So you're probably looking at about the same, to be honest. And that also counts for hysterectomy as well. It's about the same.
Okay, Steve?
Yeah, maybe the hysterectomy would be a little bit more expensive. If you're doing laparoscopically and it's long and hard, maybe longer to get the time.
Sure.
Yeah.
Sure.
Yeah.
Sure.
Yeah. Habib has asked another question. Do you think AMH should be checked before and after the UFE? Alan Upson has suggested that this should be done as a medical legal sort of preventative measure. What do you think, Femi?
I think so. I mean, I think we don't have, you know, like I said, the data is not out there, you know, in terms of yay or nay, whether your AMH will get knocked or not permanently. I think the figures that I mentioned, if you're close to 45, there's a higher chance of you getting a minority, should be discussed with the patient. So proper counseling should be done. That we should always, you know, not forget that. AMH doing prior and doing after, it just depends on what the patient is. I mean, if the patient has completed a family and there's not much else that, you know, that you're doing, then there's probably no point. In the younger patient, perhaps not a bad idea to do AMH. And probably I would say do it maybe 6 months and then 12 months later, because there's some recovery in those younger patients. So it's not a bad thing, it's good practice to do so. But I think what's important is probably just to make sure that those patients are properly counseled.
All right. And
Thank you
then,
much, Femi. Yeah.
Yeah, sorry. I was going to question about high frequency ultrasound. Is it something that's being done? I mean, is there an option comparison?
Yes. So high frequency ultrasound is offered, as far as I know, in Joburg. I don't know if anybody offers it in Cape Town. Again, Gary will tell us, I don't think it's available in Cape Town. And you have to choose your patients carefully. So in other words, UFE is something that is probably more generally applicable to patients with fibroids than if HFUS is. There's a stricter criteria for those patients, and the exclusion criteria is wider. So in other words, you're more likely to find UFE being more useful than the HFUS is, generally speaking. But it's a useful tool to have if you have it available, and something that you can use as well.
Thank you. Can we just have a comment? Do we have Gary on the line? And would you wish to comment just for completeness and balance? Gary? Or not? Doesn't sound he's on the line, Femi.
It did. Maybe we need to be on.
He is on, Pete. He is on, but he's not on the panel. He's not a panelist, and I think he said
he can't comment.
I don't think he was driving, so you wouldn't want him to have an accident. So if he appears and he's able to give a comment, yeah, maybe we need to leave it.
Another question, Steve. Do you have any more or not?
There's a question from Ali Marudu. In terms of counseling the patient, how should they expect the symptoms to resolve, and how soon can they attempt a pregnancy thereafter?
So there's no, to answer the last one first, there's no line as to when they can start trying to conceive. Once they feel better, they can start trying. The pregnancy will happen when it happens. So that's the first thing. But counseling regarding what to expect, like I said, the first 48 hours is the tough one. So usually these patients are admitted and we give them a PCA pump. So you need to be quite aggressive in terms of controlling their pain and their symptoms, as far as nausea and all that is concerned. Beyond that, they would have some pain which will require analgesics, but return to full activity is usually within 7 days or so. Sometimes even less, 7 to 10 days, so to say, is what is normally quoted, which is a bit sooner than what you will get with the other options that we have.
Thank you very much.
It's more painful than you maybe think. So I think it is something that needs to be counseled. It can be quite painful. So I see that Faisal Danger said that Hi-Fi is currently offered at Chris Baragwanath Hospital in Joburg. So thanks for that. Was there anything else from your side? Graham Birdsey wants to know where the lovely picture is from. Maybe Pete should have a guess.
I can tell you right now, that's from Switzerland. That's from the Matterhorn Mountains,
I think it's
overlooking Lake Lucerne in Switzerland.
No, nothing as exotic as that. This is Neisner Heads.
Yes, of course, it's Neisner Heads. I was just pulling your leg up. And then Alan Alperstein would like to thank you for a wonderful, it's not a question, it's a comment. Thank you for a wonderful talk, Femi.
Send my love to Alan.
Academic as always, and thanks to Alan for being on the line. Well, Steve, would you like to thank Femi?
No.
Well, thank him then, Steve.
Really put a lot of effort into this later. Yeah, I'm thanking him, and we do appreciate it. And we look forward to maybe having a more general talk about this as well, and just the technicalities, patient selection. So maybe we can get you on soon. I think you've got something like that up your sleeve, so maybe we can do that soon.
I'd love to.
Gary has actually said that he joined. And if someone has a question for him, I don't know. But
I think we just wanted him to comment generally if there was anything he wanted to say regarding.
He can't comment because he's not a panelist. In South Africa, Femi, could you just comment on where this procedure is available and by whom? Because we have a wide variety of people, as you know, from the whole of our country. So if you could just say where is it done and by whom? Do you have an idea?
I do. So I mentioned the two guys, Gary on the line and Andrew Lawson, and they tend to they don't tend to work just in Cape Town. So they have the practice in Joburg as well. And I think Andrew practices as far as Namibia, actually. So the
and Botswana. He goes right around the country and the whole of Southern Africa.
That's right. So he goes that far. So that's all. But having said that, there are a lot of people, I mean, in Kingsbury, and I think recently at UCT, there are a number of interventional radiologists that have approached me and say, we do this stuff. They got fellowships from Canada or wherever, Australia, and they're back in the country. So there's a few of those around that I don't have any experience with them because these are the two guys I work with. But it is available. There will be interventional radiologists in most, perhaps I venture to say, in a lot of hospitals that have interest in doing it. But perhaps we should try and limit it to guys who do it all the time and have the experience and who have enough numbers up their sleeve so that we don't then start mixing things up. That would be my control, yeah.
And a final question from Ali Murudu. Should we expect a complete disappearance of the myoma or just a reduction in size? How much reduction in size can you typically expect? 40%?
Yeah, so 42. And I don't know if that slide came up at all. I might have missed it, but actually what is quoted in the literature is between 40 and 80%. So that's what's quoted in the literature over a period of about sort of 12 months, perhaps a bit more. But we also know that the fibers continue to shrink, not at the same rate going forward. So you would get, sort of a further shrinkage as you go, but it doesn't completely disappear, to be honest, most of the time. I've scanned patients years down the line and there's still a classified fibroid there. So it gets really small, but over the years, but it doesn't completely disappear.
Femi, and do you find that the omentum goes to stick on the embolized fibroid? Is this a common phenomenon?
No, to be honest, no, because I have done laparoscopies on patients who've had embolizations done before, obviously not a lot, but I don't think the omentum gets that interested, probably because it's a generalized in that fibroid. The fibroids we deal with, there are just so many of them. The uterus just gets, probably gets angry for a while or less angry. So I don't find that the omentum is a problem, to be honest, when I've gone back in there.
Okay. Well, Femi, it's been wonderful having you, and I speak on behalf of over the 100. There's been a wonderful interest over here. Several hundred people have logged on, and I speak on their behalf as well. And I'd like to thank you and Steve and the Pelvic Floor Foundation directors for this wonderful talk. We'd love to have you again in the future, and we thank those people that are doing it. Some people, as we've seen, Andrew's done hundreds and hundreds of cases, and it's wonderful to have the facility and the resource that we enjoy in this country of people that are prepared to talk. So next week, ladies and gentlemen, remember we have that talk then on the urological conditions during pregnancy by Dr. Klucher. So Steve, thank you. Would you like to have the final word? Steve?
Well, Peter, Gary Soetwas is actually on now. Yeah, sorry. Yeah. Gary Soetwas is actually on the a panelist. So if there's any burning question for him, we can. Maybe just one last comment from Gary, if he wants to say something about the fertility aspects from his experience.
Yeah, Gary? Thanks so much. Thank you, team. Thank you for allowing me to join you. And Femi, excellent review. We've worked for years together, so we're very much on the same hymn sheet. But it has been really, really difficult as a radiologist trying to explain this to gynecologists and fertility specialists, especially, and having Femi's support has really changed the game for us, because it's a hard sell to change your kind of approach to something you know a lot about. I just want to just emphasize a couple of points. The data that we have, as Femi pointed out, is basically 16 years old. There's a randomized trial which showed 58 patients and 63 patients, and effectively showed for for myomectomy. That was the MORA trial. So we are, if you want to know about pregnancy versus myomectomy in a randomized way, that's the only data we have, and it's very, very poor and very old. And the problem is mainly the ethics around randomizing patients to surgery or no surgery for something that's important as fertility. So everything else since then is retrospective or cohorts, and I don't know how to solve that problem, and I would love to join anyone in trying to figure that out, whether we can set up some sort of way of comparing these two groups. So I just wanted to point that out, and that for me is the basis of the recommendations of the big groups, is lack of data and poor data. So that's really not evidence. One of the questions comes up in my practice is what we do about the intracavitary fibroids. My understanding is if we can clear the cavity, we could get better outcomes for fertility. And I'm trying to get gynaes to join with me in clearing the cavity and letting me deal with the other fibroids. So that would be a joint approach. And Femi and I have quite some experience with that. We haven't put it on a slide, but it's maybe something we'll consider doing an embolization followed by myomectomy, and what's the right case for that and how that works, just opening the conversation. And then the last thing I just want to point out is, obviously I get the outliers, the patients who are very poor risks and have been refused or can't have surgery. And then I get patients who get pregnant, and then every single patient says to me, why didn't my gynae tell me about this? Obviously they came via gynae, so they've done a lot of research, and I think it's just a reality of current gynae practice. Patients want it, and how do we select the right patients and communicate properly?
Great.
Thank you, Gary. Steve?
Yeah, thanks. And I mean, it's been a great session, and I mean, it's just something to think about and to offer your patients as an option. And certainly data is increased, experience is extensive now, 16 years, and we've got the skill in Cape Town and in the rest of South Africa. So I think it is something to suggest to your patients as an option. But thanks so much, and I think that brings us to the end, Pete. Thanks so much to everybody.
It does, Steve.
Yeah.
Safe home. Steve, thanks very much indeed for being with us this afternoon.
Yes,
and a special thanks to Femi. Looking forward to seeing you at some stage in the future. And it's been a wonderful session. Look forward to seeing you next week. Same time, same place, except Dr. Judith Klucher on urological conditions during pregnancy. Steve, that's right up your alley as well. So a great big thank you to those. Thank you to our technicians, Wendy. And see you safe home. See you all same place, same time next week. Thank you very much. Good night.
Night.
Thank you.
Thank you very much, Doctor.
Thank you. That was great. I think it was. Yeah, and everything went smoothly. So well done.
Brilliant.
Lovely. Thank you so much for your effort.
It was superb. Thank you, Femi.
Yeah. Well, thanks. Not a pleasure. Don't mind, guys. It was fantastic. Thanks for having me.
And you're in high demand. So.
Yeah. But Steve, you owe me a whiskey. Or do I owe you one? Is it still there?
Yeah, Dr. Young is still there. I'll make sure that
very great. Wonderful. Good attendance. Yeah, that was great.
No, sounds good. Have a good one, Pete. We'll chat to you soon. Thanks for the referral, Pete. Always a pleasure.
Yeah, Steve. I was just thinking that I know that is online.
We're gonna miss you walking them down to me.
I think we have to be slightly more. Well, she said she was going to phone you and give you contact.